So, neurological consultations, how do we approach this? So, we think about the golden minute, giving patients that initial time with their presenting complaint, and it's quite rude to interrupt a patient at this point. So, I highly recommend hearing them out for that initial sort of bit. At this point, I will point out that some people ask ICE, ideas, concerns, expectations, or the impact that these symptoms are having on their life. Some people save it for a little bit afterwards. Then I think it's quite relevant to think about the history of the presenting complaint, family history as well. Confirming the past medical history, any current medication would be very relevant. Social aspects, smoking, alcohol, relationships, and of course, red flags. So, red flags is really important to determine our setting for which we care for this patient. I often tend to ask red flags a little earlier on, perhaps before we explore the past medical history, but everyone does it quite differently. And the important aspect is that you're getting all the data gathering done by the 6 to 7 minute mark. Otherwise, we're going to come across as unstructured, not knowing exactly where we're going with our differential diagnosis or investigation, and we're not demonstrating how to narrow down a broad field to a few working diagnoses. And that is certainly really, really important. I'll be talking about red flags a little bit more. Consider, of course, summarizing at this point. It might buy you some time, give you some cognitive space as well to recognize where you're going with this. Maybe think about some key red flag questions that you haven't yet asked, but be sure to be sticking to that 6 to 7 minute mark to do the data gathering before you move on. Next, of course, your interpersonal skills should be weaved throughout the 12-minute consultation. There's a little bit from the data gathering in terms of offering appropriate empathy, recognizing cues, recognizing where things might be difficult for a patient, exploring further in terms of their social history or other aspects in terms of who they live with, etc., etc. But if we move on to the management section, I think about medications as the last step in this. We should be thinking about investigations to rule out or rule in your differential diagnosis, to narrow things down and to think about eliminating certain possibilities. We should of course think about referrals when we do need to get a specialist involved, and again, our red flags can certainly point towards this, as well as your history of presenting complaint. It's really important to think about your non-pharmacological interventions, and that isn't just in terms of giving patients exercises, etc. It's also about empowering your patient in terms of giving them further information, other sources in which they can get good quality, genuine information about their condition, about their symptoms, and it might help with the next few aspects as well of safety net and follow-up, which are really important. So make sure you're doing all of these things before you even consider getting onto medications, because medications is what we've been trained to do, and it's the most obvious aspect of our management plan. But make sure you're covering all of these other things before you even consider medications to offer the patient. Yeah. Next, in terms of our safety net, this is very, very important and key. So safety net should include symptoms that are worsening or red flags that mean that you want to intervene at an earlier point. So it might mean that there are certain symptoms that come up that suggest the patient needs to attend hospital immediately or get in touch with us immediately. Conversely, it means that it might be there's a progression of symptoms. We use time as a diagnostic tool. Things are changing and evolving over time, and we might need to revisit the situation, re-recognize what the priorities and the issues might be. Perhaps we're waiting for some investigations. Perhaps there's something else that has happened in the meantime that means that we have to change our approach towards the patient just to make sure that we're a safe doctor.